All right, welcome back to chapter 37, Obstetrics and Care for the Newborn. We'll cover the anatomy and physiology of the obstetric patient, antepartum or pre-delivery emergencies, and labor and normal delivery, abnormal delivery, and care of the newborn. All right, your case study intro. EMTs Lacey Schroeder and Alan Phillips arrive on the scene of a dispatch for an OB call to find an obviously pregnant woman in her 30s who appears to be uncomfortable and anxious. I'm only 35 weeks, she says. The baby shouldn't be here for another month, but I think they're coming now. At 35 weeks of gestation, what is the risk of distress if the baby is born now? How should the EMTs prioritize the order of the information they need? What factors will determine whether there is time to transport the patient to the hospital? Childbirth is a natural process. On occasion, EMTs assist with out-of-hospital delivery. Complications of pregnancy, labor, and delivery are not common, but EMTs must be prepared to manage them when they occur. Alright, anatomy of pregnancy. Ovaries, they produce hormones, release eggs or ova. Fallopian tubes, fertilization of the ovum may occur. Transport ovum to the uterus. The uterus has three sections: the fundus, body, cervix. The cervix dilates to allow delivery. Three layers: endometrium, myometrium, and perimetrium. The smooth muscle layers contract during labor, allows development of the fetus. The placenta, temporary organ of pregnancy attached to the inner uterine wall, highly vascular, provides for fetal nourishment and waste removal, separates from the uterus after delivery and is expelled. The umbilical cord attaches the fetus to the placenta. The umbilical vein carries oxygen and nutrients to the fetus. Umbilical arteries carry deoxygenated blood from the fetus to the placenta. Amniotic sac encloses the fetus, contains 500 to 1,000 milliliters of amniotic fluid. It may rupture at the beginning of labor. Vagina, lower portion of the birth canal, extends from the cervix to an external opening of the body. And here we go, there's a picture of all that. We see at the top, we see the placenta, the fundus of the uterus, that wall, the uterus itself, and then we have the umbilical cord. We see it coming around and attaching to the baby's belly button. The cervix, and that's where they're checking for dilation whenever they see how far along the woman is dilated. Amniotic fluid is what the baby is encased in the amniotic sac. And the birth canal, the vagina. And you need to study this and become familiar with it. You need to kind of have this in your mind, what's going on. The menstrual cycle. The cycle averages 28 days and is controlled by estrogen and progesterone. The first day of the cycle begins with menstruation. During the menstruation, the endometrium is shed. After menstruation, the endometrium is rebuilt. So the shedding of the endometrium is what causes the blood from the menstrual cycle. The prenatal period. For the first 14 days, the fertilized ovum is in the pre-embryonic phase. The period from day 15 to 8 weeks is the embryonic stage. The period from 8 weeks to birth is the fetal stage. At birth, the baby is called a neonate. Pregnancy lasts 280 days or 9 calendar months. Physiologic changes in pregnancy caused by hormones, growing fetus, and increased metabolic rate. Many body systems are affected. The reproductive system. Uterus substantially increases in size. The uterus is extremely vascular and contains about 1/6 of the mother's blood volume. A mucus plug forms in the opening of the cervix. The breasts enlarge in preparation for lactation. The respiratory system. The mother's oxygen demand increases. Respiratory tract resistance decreases. Tidal volume increases by 40%. Respiratory rate increases slightly. Oxygen consumption increases by 20%. The cardiovascular system, cardiac output increases, maternal blood volume increases, maternal heart rate increases by 10 to 15 beats per minute. Blood pressure decreases slightly in the first and second trimesters and returns to normal in the third trimester. Gastrointestinal system, nausea and vomiting commonly occur during the first trimester. Bloating and constipation may occur from a decrease in peristalsis. And peristalsis is a series of wave-like muscle contractions that moves food to different processing stations in the digestive tract. So that's what peristalsis is. So whenever everybody digests their food, everybody goes through peristalsis. So a pregnant lady is going to have a decrease in peristalsis, so they're going to be more bloating and constipation. The urinary system, renal blood flow increases. I always have a problem pronouncing this. Glomerular. I know you're probably laughing at me. Glomerular filtration. I think I got that right. Increases in glomerular filtration is the function of the kidneys. So that's where the kidneys are functioning and filtering and things like that. And it's there's a rate that it goes by, and it increases during pregnancy, causing probably a lot more urination and such. So that being said, the urinary bladder is displayed superiorly and anteriorly, increasing the risk of injury. So it's going to be up and out the front. Urinary frequency increases in the first and third trimesters. So there you go, because of that increase in filtration. The musculoskeletal system, the pelvic joints loosen as a result of hormone changes. The center of gravity changes caused by the heavy uterus, accompanied by lower back pain. So what it's saying is that pregnant ladies are gonna feel more back pain, lower back pain, plus they're gonna be off center. And unlike us, who can keep our balance well, pregnant ladies have to readjust, and that's what causes their lower back pain. All right, antepartum condition, or hyperemesis gravidarum, is extreme morning sickness accompanied by severe nausea and vomiting. Increased hormone levels may cause a severe nausea and vomiting. I have 2 children, and I've experienced their mother pregnant 2 times, and people say that these symptoms or these things are not as bad the second and third time around. I'm here to tell you that that is incorrect. At least it was for us. She had the antepartum condition, the hyperemesis gravidarum, where she was sick a lot the first trimester, and the hormones were out of whack, let me tell you. All right, so you're going to assess this by seeing severe nausea, severe vomiting, excessive salivation, headaches, syncope, and jaundice, possibly. We all know, let's go back to what jaundice looks like. It's going to be the yellow color of the mucous membrane, especially the whites of the eyes, of the skin, that sort of thing, okay? Emergency medical care is primarily supportive. I mean, I don't know what you're going to do. BLS trucks can't give any medication for nausea and vomiting. Paramedics can, so you definitely want to be able to make sure you got ALS en route. Ensure an adequate airway, ventilation, and oxygenation. That's going to be your supportive care. Antepartum conditions causing hemorrhaging. Uterine bleeding may or may not be associated with vaginal bleeding. Hemorrhage may be life-threatening. Causes include spontaneous abortion, placenta previa, abrupto placentae, a ruptured uterus, and ectopic pregnancy. Now, let's go over some of those things. Spontaneous abortion is a miscarriage. So that's just another word. They're not having an abortion. I mean, at a clinic, the baby is aborting itself. So just so you understand, that's what that is. Placenta previa is a condition in which the placenta, partially or wholly blocks the neck of the uterus, thus interfering with normal delivery of the baby. So the placenta is detached or moved down from where it's supposed to be in the uterus, and it's blocked that birth canal opening, so that it's going to be almost impossible to deliver the baby if in the pre-hospital setting. Abruptio placenta is, as we talked about earlier, where the placenta ruptures, causing some bleeding. We definitely don't want that. Ruptured uterus is just that. We definitely like abruptio placentae, ruptured uterus are bad because of hemorrhage, and there could be a lot of blood loss and a lot of shock, or possibly your patient going into shock. An ectopic pregnancy is where the fetus develops outside the uterus, typically in the fallopian tube. So there are different signs and symptoms of this, which you might see is pain in the pelvis, the abdomen, or side part of the body, gastrointestinal bloating, nausea, or vomiting. Also some abnormal vaginal bleeding or cramping. And that's obviously you're just going to treat. You're not going to be able to tell if it's in an ectopic pregnancy, but you're definitely, or even if it's a placenta previa, because you're not going to like do a full inspection, probe or anything like that. You're going to have to take her to the hospital so she can get examined by gynecologists or doctors. That way they can find out exactly what's going on. Probably some ultrasounds involved and that sort of thing. All right, a spontaneous abortion is a miscarriage. Delivery of the fetus and placenta before the fetus is viable, which is before 20 weeks of gestation. So if a baby is born before 20 weeks of gestation, it is a spontaneous abortion, and it is not viable. I'm sorry to tell you this. It's very sad, but you will not be able to save that baby. Most often occurs before 12 weeks of gestation. Your assessment, you're going to see cramp-like lower abdominal pain similar to labor, moderate to severe vaginal bleeding, which may be bright or dark red, passage of tissue or blood clots. So if the girl tells you that she thinks she's had a miscarriage, you need to see. Hopefully she didn't flush it, or let you see what it looks like. And if you can, I know this is going to sound delivery, collect it and bring it with you. Ectopic pregnancy, a fertilized ovum is implanted outside the uterus, usually in a fallopian tube. The tissue which surrounds the developing embryo ruptures. And that's what we're going to see right here. Outside of the wall of the uterus, fallopian tube, locations. These are locations of an ectopic pregnancy here, in the abdomen, fallopian tube, that sort of thing, okay? Nothing you're going to be able to tell. You're just going to have to treat for the signs and symptoms, keep your patient comfortable. Assessment, you're going to see a dull aching pain, shoulder pain possibly, because pain refers to other places of the body. Vaginal bleeding, tender, bloated abdomen, palpable mass in the abdomen, and decreased blood pressure. Emergency medical care is follow the general guidelines for emergency medical care for a pre-delivery emergency. So you're just going to follow those protocols and get her to the hospital. All right, placenta previa, antepartum conditions causing hemorrhaging. The pathophysiology is condition is caused by an abnormal implantation of the placenta near or over the cervix. Excessive bleeding can occur as the cervix begins to dilate. The bleeding is painless. Hemorrhage may be total, partial, or marginal. Anticipate and treat the patient for shock. Remember, anytime we have a hemorrhage, we want to make sure we treat our patients for shock. And there it is, placenta previa. That placenta should be up here somewhere, but it has moved or grown right here. Okay, and if it ruptures, you're going to see some bleeding, severe bleeding. Abruptio placentae, abnormal separation of the placenta from the uterine wall prior to delivery. Fetal, that means for the baby, a reduction in fetal blood flow causes fetal hypoxia. inadequate nutrient delivery, and poor elimination of carbon dioxide and other waste products. Maternal, severe hemorrhage and hypovolemic shock. This is for your mother, maternal. And that's what it's going to look like. It's separating, and you see the blood flow coming down through the uterus. Your assessment, you're going to see vaginal bleeding, abdominal pain, lower back pain, uterine contractions, and symptoms of hypovolemic shock. Which, I'm going to say this, and you should know this already, you're going to tell by a skin condition. If you have a pale, cool, clammy skin, diaphoretic, and they're bleeding somewhere, then you are pretty much looking at a patient that's about to be or is in shock. Emergency medical care. Administer the same cares for placenta previa. Administer concentration oxygen. Treat for hypovolemic shock. Ruptured uterus. Possibility of the uterine wall rupturing, releasing the fetus into the abdominal cavity. Not a good thing. Has a high mortality rate, unfortunately, and severe maternal hemorrhaging and severe fetal distress. Requires immediate surgery. And unfortunately, that's what it looks like. Torn edge of the uterus, and the baby is going into the abdominal cavity. It's a really bad situation. You may have a history of previous uterine rupture, a history of abdominal trauma, more than 2 previous births, prolonged difficult labor, constant severe abdominal pain, signs and symptoms of shock. Your emergency medical care is be to follow the general guidelines for emergency medical care of a pre-delivery emergency. You're going to get that baby, then his mother, to the hospital. All right, antepartum seizures and hypertensive emergencies. Seizures during pregnancies. Status epilepticus is especially dangerous. We talked about status epilepticus when we talked about having seizures. Provide the same care as for any seizure patient. Transport the patient on their left side or with their right hip elevated at a 15 degrees to the left if they are greater than 20 weeks gestation. That is to do what? Lift that baby off the vena cava. Pregnancy-induced hypertension, maternal blood pressure greater than 140/90 on 2 or more occasions of 6 hours apart. Resolves upon delivery of the baby. So the mother of my children had hypertension, and after she gave birth, the hypertension went away. Okay, preeclampsia and eclampsia. Preeclampsia occurs most frequently in the last trimester and is most likely to affect women in their 20s who are pregnant for the first time. Eclampsia is a more severe form of preeclampsia and includes coma or seizures. What happens is, and the pathophysiology of these two are history of hypertension, diabetes, kidney or renal disease, liver or hepatic disease, or heart disease. No previous pregnancies, history of poor nutrition, and sudden weight gain. Assessment, altered mental status, abdominal pain. Give me 1 second. Blurred vision or spots before the eyes, excessive swelling of the face, fingers, legs, or feet. And preeclampsia is a condition in pregnancy characterized by high blood pressure, sometimes with fluid retention and proteinuria, protein in the urine. And eclampsia is a condition in which one or more convulsions occur in a pregnant woman suffering from high blood pressure, often followed by a coma. So preeclampsia is going to be hypertension, and then eclampsia is going to be convulsions or almost seizures caused by high blood pressure. Supine hypotensive syndrome is what we talked about earlier. Complication occurs in the 3rd trimester. The weight of the fetus compresses the inferior vena cava when the patient is lying in the supine. You're going to see dizziness or lightheadedness when in the supine position, tachycardia, cool, clammy skin, and a decrease in blood pressure. Your emergency medical treatment is to lift the pregnant lady from their right hip 15 degrees. Okay, scene size up. Consider the dispatch information. Any female between 12 and 50 could potentially be experiencing an obstetric emergency. Primary assessment: take standard precautions, assess the mental status, airway, breathing, and circulation. Your secondary assessment: gather a history, examine the abdominal region, obtain a set of baseline vital signs. Include appropriate questions such as, have you ever been pregnant before? If so, how many pregnancies, which is gravida. Gravida is how many pregnancies, and how many pregnancies resulted in live births. So pregnancies is gravida, para is live births. So if a lady tells you 4 and 4, that means she's had 4 pregnancies, 4 live births. If she's told you 4 and 3, that means she's had 4 pregnancies, 3 live births, 1 did not make it. Have there been any previous complications, and when was your last normal menstrual period? Signs and symptoms: abdominal pain, nausea, vomiting, vaginal bleeding, passage of tissue, weakness, dizziness, altered mental status, seizures, excessive swelling of face or extremities, hypertension. Emergency medical care: provide the pregnant patient with the same emergency medical care you would provide to any patient with the same signs and symptoms. So that being said, let me shorten that up. We're treating the patient for the signs and symptoms. If a patient is at 20 weeks of gestation or more, position them to avoid supine hypotensive syndrome. During your reassessment, if the patient is stable, repeat every 15 minutes. If unstable, every 5 minutes. Maintain the mother's circulation and oxygenation. Maintaining the mother's circulation and oxygenation is critical to saving the fetus. Performing CPR on the mother may save the fetus. All right, labor. This process consists of contractions of the uterus, which expels the fetus and the placenta out of the uterus and vagina. Normal labor is divided into 3 stages: dilation, expulsion, placental delivery. And here we go. First stage of labor. This is stages of labor, not pregnancy. The first uterine contraction to dilation of the cervix. Second stage of labor, the birth of the baby or expulsion. Third stage is the delivery of the placenta. All right, first stage dilation, stage 1 for a first-time mother, lasts 8 to 10 hours and 5 to 7 hours in a woman who has had a child before. At the end of stage 1, contractions are irregular 3 to 4 minute intervals, last at least 60 seconds each, and feel very intensive. Braxton Hicks contractions are not labor. Braxton Hicks are just contractions. They are just muscle contractions. They are not labor. It's not the uterine wall contracting. It's the muscles in the abdomen. It's going to give off a labor type feel. The frequency or interval is the time between the start of contractions. The duration describes how long the contraction lasted. The intensity or strength of the contraction describes the amount of pain associated with the contractile force. The second stage or expulsion: during the second stage, the infant moves through the vagina and is born. Contractions are less than 2 minutes apart and last 60 to 90 seconds each. As the infant moves downward, the mother experiences considerable pressure in their rectum. Okay. Second stage expulsion: the perineum bulges, indicating impending birth. The infant crowns. After the head delivers, the body follows. The third stage is the placental delivery. In the third stage, the placenta is delivered, usually within 5 to 20 minutes. Do not pull on the umbilical cord to facilitate the delivery of the placenta. Your scene size up: primary and secondary assessment. Determine if delivery is imminent. It is best to transport a mother in labor so that the delivery can occur at a hospital. Estimating the gestational age based on fundal height. The closer the top of the fundus, which is the outer lining of the uterus, is to the xiphoid process, which is the very bottom part of the sternum, the higher the number of weeks of gestation. So the closer the top of that uterus, that fundus, is to the xiphoid process, the higher the number of weeks of gestation. Gestational age by landmark: fundus at the umbilicus is 20 weeks, and the fundus at the xiphoid is 38 weeks. Pre-hospital delivery: there is no suitable transportation. The hospital or physician cannot be reached due to bad weather, a natural disaster, or catastrophe. Delivery is imminent. These are the reasons why you would have a pre-hospital delivery. Imminent delivery: determine if the delivery is imminent by has crowning occurred, which if you inspect the mother's vagina, you see the baby's head, any part of the head. Are contractions less than 2 minutes apart? Do they last 60 to 90 seconds? Does the patient have the urge to defecate? And does the patient have a strong urge to push? Is the patient's abdomen extremely hard? Take standard precautions. Do not touch the vaginal area except during delivery. Do not allow the patient to use the toilet. Do not hold the mother's legs together. Use a sterile obstetrics kit. Click on the finding that should prompt you to anticipate the need for immediate on-the-scene delivery. If you chose D, the mother states that she needs to have the field to defecate. You'll be correct. As the baby descends into the birth canal, the mother will have a feeling of pressure on the rectum, such as that caused by the need to have a bowel movement. Delivery at the scene. Take all appropriate standard precautions. Position the patient. Apply oxygen by nasal cannula at 2 to 4 liters per minute. Create a sterile field. Anticipate vomiting and assess for crowning. Here's a basic obstetrical kit. You're probably going to need more towels, so you might want to bring 2 obstetrical kits. Apply gentle pressure to the head to prevent an explosive delivery. Sorry, this starts getting into the point where I want to laugh a lot. Tear the amniotic sac if not ruptured. Assess for the possibility of the nuchal cord. Nuchal cord is going to be the cord wrapped around the baby's neck. Suction the airway only if needed. Delivery anterior, then posterior shoulder. Deliver the anterior, then the posterior shoulder. So whatever shoulder is facing the mother's front, deliver it first. Support the baby's body with both hands as it is delivered. Secure the baby's head, neck, and body and grasp the feet to complete the delivery. Dry the newborn with towels, clamp the cord, and use sterile surgical scissors or a scalpel to cut it. This will all be in your OB kit. An APGAR score should be done 1 minute and 5 minutes after birth. Delivery at the scene. Keep the newborn dry and warm. Deliver the placenta. Stand by for just a second. Place a sanitary pad of sterile dressings over the vaginal opening and perineum. Control postpartum hemorrhaging. Record the time of delivery. Transport the mother, newborn, and placenta to the hospital. Now, an APGAR score is going to be appearance, pulse, grimace, activity, and respirations. So those are the things you're going to assess with APGAR, and you're going to give appearance is skin color, pulse is obvious, grimace is reflex irritability if you agitate, do like a little sternum rub and it agitates the child. Muscle tone, are they limp, or they actually moving their arms and stuff around, and what's their respirations, and then it scores by point. Okay, here comes the fun part. Y'all asked for this. Crowning. The vertex of the head is showing in the vaginal opening. That's a lot of crowning. It doesn't have to be that much crowning to be imminent. Okay, I'm just telling you. There we go. Once the head is delivered, check if the umbilical cord is around the neck or nuchal cord. Deliver the shoulders with the next contraction. So the anterior shoulder is going to be delivered out here, then the posterior shoulder, because this is the mother's anterior, correct? Correct. Oh, kaboom. There it is. All that amniotic fluid just spraying everywhere. Ugh, sorry. Once the shoulders are delivered, the entire torso is likely to be delivered quickly. So, just saying, be prepared. Here it comes. Okay, very, very slippery, so get ready. And maintain a good grasp on the newborn and keep the baby level with the mother's body. Please don't drop the baby. Please don't drop the baby. Hey, I'll say it again. Please don't drop the baby. Provide the newborn care, keeping the baby dry and warm. That's a cute little baby. Clamp and cut the umbilical cord. So we're going to clamp the cord 6 inches away from the baby's body, and then 2 clamps are going to be 2 inches apart, and then we're going to have, if dad's there, let him cut it. If not, you cut it. Oh, there it is. There's the placenta. Fun fact, not really fun, but fact, Some people like to take this home and eat it. Ugh. I'm sorry, that's just making me sick. If there's anything you don't know about me, is that I can't stand other people's fecal matter or fluids from baby delivery. It's just disgusting. All right, blow-by oxygen. So we're going to provide blow-by oxygen on the baby. We're not going to put that mask on his face. We're just going to put it about an inch or two away from his face. Let that oxygen blow by, okay, depending on their SpO2, skin condition, that sort of thing. All right, back to the case study. Whew, thank goodness. Lacey reassures the patient and explains that she needs to check and see if the baby is about to be born. Lacey confirms that the delivery is imminent. Lacey pulls on a gown and eye protection, and Alan prepares the OB kit. Within 10 minutes, Lacey has assisted with the delivery of the baby girl. What steps are required in the immediate care and assessment of the newborn? What special consideration should be taken if a newborn is premature? Okay, pause the video, write these questions down so that you can answer them as we go along. Abnormal deliveries, signs and symptoms, assessment-based approach, active labor with abnormal delivery, scene size up, primary and secondary assessments, any presentation besides normal crowning, meaning if there's an arm, leg, or anything, the butt hanging out of the woman's vagina, then that's an abnormal presentation. Umbilical cord protruding from the vagina, that's abnormal. Amniotic fluid with an abnormal color or smell, that's abnormal. Emergency medical care and reassessment, emphasis on immediate transport. If we have an abnormal presentation other than crowning, we are not delivering that child. Okay, we are elevating the mother, we're closing her legs, elevating her lower torso, and we are taking her to the hospital as fast as we can. Immediate transport, administer oxygen, continuously monitor vital signs. All right, intrapartum emergencies. Prolapsed cord. The umbilical cord is the presenting part. The cord may be compressed, cutting off oxygen to the infant. So what's compressing it will be the cervix, okay? Instruct the mother not to push. Administer high concentration oxygen. Put the patient in a knee-chest position. That means put her knees to her chest. Okay, elevate her hips, administer oxygen, keep her warm, keep the baby's head away from the cord. Do not attempt to push the cord back in. Wrap the cord in a sterile, moist towel. Transport the mother to the hospital, continuing pressure on the baby's head. A breech birth. The buttocks or lower extremities are presenting. This condition presents a high risk of fetal complications. Transport in the supine, head down position. That means her head is lower than the rest of her body, and you have that body up, and so that gravity can take effect and not let that baby come out. You should not attempt to deliver a breech presentation in the field. Please do not. All right, there's a breech delivery, but you can see all those handy dandy scrubs and gowns. They are in a hospital. If a pre-hospital breech delivery is unavoidable, contact medical direction for assistance. Have the mother push hard during contractions. As the infant delivers, support the legs. Allow the legs and buttocks to deliver until the umbilicus is seen. A breech delivery with an entrapped head. Immediately begin emergency transport. See that? Read that again. Immediately begin emergency transport. Administer high flow oxygen. Insert a gloved hand into the vagina and attempt to manually push the cervix over the head of the entrapped fetus. So this is why you need to know your anatomy, okay? And this is what it's going to look like. That fetus is going to be opened a little bit, enough so they get the baby's body out, and then so you can be able to feel it pretty open there. And this is called the Morso maneuver. As you can see, somebody's going to push down on that uterus right here. Okay, you're going to put your hand over that baby's back, push down that head, and you're going to do like a swooping motion up. Pull that out like this, and it kind of like I don't know, like an underhand throw backwards or something like that. But keep that pressure on that uterus so the baby doesn't slip back in. Face, chin, brow, limb, and compound presentations. An arm or leg is the presenting part. Vaginal delivery is impossible. Administer oxygen and transport the patient in an knee-chest position. Okay, pre-hospital delivery is impossible. We're not delivering this child if we see this. Okay, it's kind of weird if we ever see it, but anyway. Shoulder dystocia. The fetal shoulders are larger than the fetal head. The head delivers, but then retracts back into the vagina. So that kid's got some big wide shoulders, probably going to play football. And the head gets sucked back in. You see normal over here, shoulder dystocia. The kid's shoulders are just way too big. So the dangers will include entrapment of the cord, inability of a child's chest to expand properly, severe brain damage, or death if child is not delivered within minutes. Emergency care for shoulder dystocia: place the patient in the McRoberts position. If the McRoberts position alone does not work, apply suprapubic pressure. That means push down on that pubical area. If the McRoberts position and suprapubic pressure do not allow delivery of the shoulders, you might be instructed by medical direction to attempt a Gaskin maneuver. So the McRoberts does not change the actual dimensions of the maternal pelvis. It relieves shoulder dystocia by a rotation of the symphysis pubis and by flattening the sacrum. So it's kind of like opening, spreading that area out so that there's more room. It's been known to alleviate 39 to 43% of shoulder dystocias. Precipitous delivery: a baby delivered within 3 hours of the onset of labor. Most common in multipares. That means these ladies have had multiple babies. Increased risk of trauma to the baby and the mother. Multiple births: be prepared for multiple births if the abdomen is still very large after one infant is delivered. Uterine contractions continue to be strong after delivering the first infant. Uterine contractions resume about 10 minutes after one infant is delivered. The infant is small compared to the abdomen. Meconium. Meconium is fetal distress. This fetal distress can lead to the fetus passing a bowel movement into the amniotic fluid. So the fetus is under distress. It has a bowel movement into the amniotic fluid. Now that's what's going to happen. Is it's going to breathe this in. Remember, we're as babies, we are in the womb. We're in that amniotic fluid. So that's coming in and out of our body. So it could if the meconium stained fluid is aspirated, so the child aspirates it, it could cause pneumonia. Medical care: if meconium is present but the newborn has a good cry or vigorous activity, do not suction. If the baby is depressed or non-vigorous and the heart rate is less than 100 or has inadequate respirations, quickly suction the nose and mouth with a bulb syringe and immediately begin PPV, positive pressure ventilation. Preterm labor occurs between the 20th and 37th week of gestation. Cocaine and other drugs are known to induce labor. Emergency care: do not allow the mother to push. Place the mother on oxygen. So we need to ask every time we deal with a pregnant lady, we need to ask, how far along are they? How many weeks are they gestation? Infant weighing less than 5 pounds or born before 37th week of gestation, prone to hypothermia and respiratory problems. Care for a premature baby: dry the newborn thoroughly. Use warm blankets or a plastic bubble bag swaddle. Use gentle suction if it is necessary to clear the airway. Prevent bleeding from the umbilical cord. Administer supplemental oxygen if needed and prevent contamination. Post-term pregnancy, which is delivery beyond 42 weeks of gestation, causes post-maturity syndrome, a deterioration of conditions necessary to support a well-being of the baby, increased risk of complications, increased risk of intrapartum hypoxia. Premature rupture of membranes or PROM, spontaneous rupture of the amniotic sac prior to the onset of true labor and before the end of the 37th week of gestation, increased risk of infection, prevents adequate lubrication of the vaginal canal at the time of birth. Postpartum refers to the period following delivery and involves the mother. Postpartum hemorrhage: a loss of greater than 500 milliliters of blood occurs after delivery. The uterus fails to regain tone after delivery. Manage this condition with fundal massage, administer oxygen, and transport the patient. Embolism: pregnant and postpartum patients are at increased risk of forming blood clots, which can lead to pulmonary embolism. Amniotic fluid embolism may occur. Patients can present with shortness of breath, syncope, tachycardia, sharp chest pain, hypotension, cyanosis, and pale, cool, clammy skin. For an embolism, ensure adequate ventilation and maximize oxygenation. Transport the patient. Okay, the care for a newborn. General considerations. Neonates lose body heat quickly. Immediately dry the newborn. Wrap the baby in a blanket or a plastic bubble bag swaddle. Suction to clear the airway only if obstruction to breathing is present. Place the newborn on their back with neck slightly extended in a sniffing position. Score your APGAR 1 and 5 minutes after birth. Score each category with a 0, 1, or 2 for appearance, pulse, grimace, activity, and respirations. Use the APGAR to determine the need for resuscitation. 7 to 10 points, provide routine care. 4 to 6 points, stimulate and provide oxygen. 0 to 3 points, provide care, including oxygen, positive pressure ventilation, and CPR. If the newborn is not breathing adequately, stimulate. If the newborn is not breathing adequately, stimulate by rubbing the back or flicking the soles of the feet. Continually assess the newborn during transport. Here's your emergency care algorithm for obstetric emergencies. You can look at this and learn it. All right. Assessment. Most newborns require only routine care. Of those who require more care, most need only oxygen and bag valve mask ventilation. A few newborns require chest compressions and advanced care. Expected SpO2 readings in a newborn are based on preductal readings obtained from the right upper extremity. The expected SpO2 takes several minutes to reach normal levels, so don't freak out if you don't get an expected SpO2 right off the bat. Targeted preductal SpO2 after birth, 1 minute, 60 to 65%. So you see, as time goes on, the SpO2 reading is going to go up. Emergency medical care. The majority of newborns who require intervention require only simple measures. Newborn bradycardia is a heart rate of less than 100 beats per minute. Labored breathing, apnea, and persistent cyanosis typically respond by blow-by oxygen or to bag valve mask ventilations. Stimulate the infant who is not breathing by flicking the soles of their feet or by rubbing their back. These 3 questions guide the need for resuscitation. Is this a term gestation? Does the newborn have a good cry, or are they breathing adequately? Does the newborn have good muscle tone? Here's your assessment initial management of the newborn. Please look over this. Some of the stuff we just went over, but you need to look over it and you need to understand it. You're going to see this stuff again, folks, I promise you. All right, interventions within 30 seconds of delivery. Dry and warm the newborn. Position the airway. Suction if there is obstruction of breathing. Stimulate by flicking the soles of the baby's feet or rubbing their back. The inverted pyramid for neonatal resuscitation shows that the majority of newborns will respond to simple routines of care. Only a few will require aggressive resuscitation. So we look over here, we see EMT, dry, warm, suction, position, tactile stimuli, oxygen, BVM, chest compressions, advanced life support, endotracheal intubation, and medications. Positive pressure ventilation, clear the airway by suction, provide ventilations by bag valve mask at the rate of 40 to 60 per minute. Reassess every 30 seconds. If breathing has not improved, continue ventilations. To provide positive pressure ventilation, use a bag valve mask. Maintain a good mask seal. Ventilate with just enough force to raise the infant's chest. Ventilate at a rate of 40 to 60 per minute for 30 seconds, then reassess. If the infant's heart rate drops to less than 60, continue ventilations and begin chest compressions. So even though they have a heart rate, if it's less than 60 beats per minute, we are doing chest compressions. To provide chest compressions, you know how to do this. Circle two thumbs in the chest, and it's if there's 2 providers, it's 15 and 2. If there's only 1 provider, it's 30 and 2. and we are doing a compression rate of 100 to 120 beats per minute. Meconium present at birth. The newborn is crying vigorously with good respiratory effort and good muscle tone. Newborn has absent or depressed respirations, poor muscle tone, or a heart rate of less than 100 beats per minute. All right, our case study conclusion. As Lacey assists the delivery of the placenta and monitors the mother, Alan determines that the newborn has 1 minute APGAR score of 7 and a 5 minute APGAR score of 8. Alan ensures that the baby is dry and warm and hands them to the mother. En route, the EMTs continue to monitor both patients who are stable on arrival at the hospital. Okay, our summary. Pregnancy results in physiological changes to several body systems. Antepartum emergencies include hemorrhagic emergencies and hypertensive emergencies. There are 3 stages of normal labor. Most abnormal deliveries cannot take place in the pre-hospital setting. Newborn resuscitation begins with simple measures such as drying, warming, and stimulation. All right, we'll see you next time.